So good morning, everyone. My name is Apu and I'm the Injury Prevention Officer at Injury Matters. And today I'll be facilitating the Falls and Cardiac Health, the Link and the Risks webinar. And joining me today will be our guest presenters, Helen McLean and Anne-Marie Dunnet. So before we start, I wanted to acknowledge the traditional custodians of the land on which I am here today, the Whadjuk Noongar land, Whadjuk Noongar people who are the traditional custodians of the land on which I'm facilitating today, this webinar, and I wanted to pay my respects to their elders past, present, as well as the leaders emerging. Australia always was and always will be Aboriginal land. And I just want to go over a few, the slides, there you go, a few housekeeping points. So I know everyone's already muted, but just double check that you are. If there's more than one person with you joining into today's webinar, I would appreciate it if you could just send us a quick private message via the chat tab and let us know how many people are joining in with you. If you have any questions for our presenters anytime during the presentation today, please use the Q&A box, Q&A tab just below at your screen, and we'll take questions at the end of the presentation. Obviously, Helen, during her presentation, will also ask a few questions, and to answer them, you can use the chat box as well. And if you are facing any technical issues during today's webinar, just write us at the chat box and we'll do our best to help you. So today's event is being hosted by Injury Matters. So a little bit about us and who we are. Injury Matters is for safer people and places, and our key purpose is to prevent and reduce the impact of injury within the WA community. And we do this through advocating and providing education for injury prevention, as well as providing support for people who have been impacted by injury. And today's webinar is through the Stay on Your Feet program with the support of the Department of Health WA. The Stay on Your Feet program provides information, training and support to older adult community members, as well as professionals working with older adults on how to prevent falls in the community. And this is done through the Move, Improve, Remove campaigns. And it kind of refers to move your body, improving your health and removing hazards for falls prevention. So before I hand it over to our speakers, I just wanted to do a bit of a quick look at falls in WA. Falls and falls-related injuries continue to be a significant public health issue in WA, and that's why we're here today. But what does that actually look like? So on average, one Western Australian dies from a fall-related injury every 25 hours, is admitted to hospital for falls-related injury every 17 minutes, attends an emergency department as a result of a fall every 13 minutes. So although it's easy to look at the stats and data, each of these statistics is a person whose life has been impacted by a fall. If you want to learn more and have a better look at falls in WA, we do have a 2022 falls report available on our website. So if you do want to have a read through that, there should be a link in the chat box as well if you want to go through and have a look. And just a bit of background before I introduce our speakers. Adults with cardiovascular disease are at a higher risk of falling. And the prevalence and specific risks for falls among older adults with cardiovascular disease are not well understood, and falls are likely underestimated in clinical practice. All clinicians who care for patients with cardiovascular disease should be able to recognize falls and to mitigate falls, risk for falling. And to talk more about the link and the risks between cardiac health and falls in older adults, I would like to introduce our speakers, Helen McLean and Anne-Marie Dunnet. Helen McLean is a Senior Healthcare Programs Officer at the Heart Foundation WA. She's a registered nurse, midwife, and has over 40 years of experience as a clinician. as an educator and also in setting up sustainable patient and family-friendly services. And Anne-Marie Dunnet, who's a physiotherapist. And yeah, I'll hand it over to you guys.
Thank you. And thank you, Epu, for inviting us to present. And Anne-Marie works in WACS in WA Country Health Service. So it's great to be here today. I'm just going to share my screen and start by acknowledging the traditional owners on the lands where Anne-Marie and I sit. And that's the Whadjuk people of the proud Noongar Nation. We pay our respects to their elders past, present and emerging. We pay our respects to their courage, their wisdom, their strength, their resilience, and their gentle spirits. So thank you for joining us today. We'll start by thanking Epu. And actually, when Epu asked that I present, I thought, oh, falls, wow. Yeah, falls and cardiovascular disease. And the more I've looked into it, I think we could be here all day. So we were requested to speak about cardiac health and falls, how they link, common risk factors, Aboriginal health statistics in a holistic lens to clinical practice, screening tools and resources. So Anne-Marie and I, we've known each other a very long time, and yeah, we'll be a bit of a tag team. So there'll be a bit of conversation. We really, really want you to put comments, anything into the chat, because sometimes at the end, you know, it's nicer to answer it while we're at that part. So, yep, please feel free. So falls are the second leading cause of unintentional injury deaths worldwide. Each year, 684,000 individuals die from falls globally. These are World Health Organization statistics, and 80% of them are in low and middle income countries. And we will go into the social determinants of health in regard to this topic. Adults over 60 suffer the greatest number of fatal falls. And of course, we will go into that with bone density, all kinds of all those cardiovascular risks that then add to the reason why the falls are fatal. 37.3 million falls are severe enough to require medical attention.
And I think that's probably backed up with Apu's introduction of one person who dies every
day,
every 25 hours,
yeah.
And you know, 13 minutes somebody is admitted or seen in the ED for a falls related injury.
Yes, every 13 minutes. Wow. So for those with cardiovascular disease, the risk of falling is 60% higher for those who do not have cardiovascular disease. For Aboriginal and Torres Strait Island people, we're well aware that they have 3 times the rate of major coronary events, such as heart attacks, than non-Aboriginal people, and 1.4 times the out-of-hospital death rate from cardiovascular disease. And we know that in the healthcare world where we work now, no one comes without comorbidities. It's very rare to see someone who has one health problem.
Especially one on its own, like cardiovascular disease, you nearly always have
Yes.
other links.
Yes, so of course with Aboriginal people, there are massive links with diabetes and small vessel disease. So diabetes compounds the stats for Aboriginal people within the Falls. And in 2020 to 21, the leading cause of injury-related hospitalisation for Aboriginal and Torres Strait Island people were falls at 21%. There are all the social determinants of health and the socioeconomic factors that play into the different reasons why Aboriginal people fall, and their stats are really bad. So poverty plays into this, overcrowded housing, sole parents, and young maternal age. And of course, a huge key driver in our health in general is the food we put in to provide our body with energy and nutrition for all our cells. And nutrition is a key driver in the gap in heart health between Aboriginal and non-Aboriginal Australians. So falls and cardiac health, why is the risk higher? So the first thing we wanted to speak to was
age of people is definitely a key risk factor. Obviously, the older an individual is, the more at risk they are. However, anybody over the age of 60 within the hospital system, certainly we tend to screen for falls risks. The older people definitely have a higher risk of death and serious injury arising from a fall when they do have one, and the risk does increase with age. That becomes significantly higher again after the age of 85 or 65 for Aboriginal and Torres Strait Islander cohort. Men seem to be more likely to die from a fall, and women have more non-fatal falls. So fall with other health consequences, contusions, NOFs, humeral heads, wrists, other fractures. Yeah. Mm-hmm. So the risk factors for the falls include alcohol or substance use. This is not just recreational drugs. It can also be in the substance use. We put in the medications, and we'll go into medications a bit more. And most of us know that using medications with alcohol will increase the risk of falls just in the general population.
Yep.
Socioeconomic factors, and Helen has gone over those: the poverty, overcrowding, housing, sole parenthood, and young maternal age. The underlying medical conditions, neurological, cardiac, or other disabling conditions. These have a huge effect. Diabetes with peripheral neuropathies, when they can't feel their feet so well and can't feel their hands so well. Side effects of medications, and again, we'll go into that a bit more. Physical inactivity, so the less you do, the less you're able to do. Loss of balance, poor mobility, reduced cognition, that comes from all sorts of different areas, not just from age. It can be medication related, it can be from vascular changes. There's lots of different reasons for reduced cognition other than just pure aging, low vision, and unsafe environments.
Yeah. So we wanted to use the American Heart Association, their diagram around preventing and managing falls in adults with cardiovascular disease. This scientific statement we will break down into each parts of that half circle. So the first part is around gait and balance risk factors.
As part of that, gait and balance is made up of lots of things really, but we are going to talk to you about frailty and sarcopenia, physical functional impairments, and general frailty. So sarcopenia, many of you will know, is muscle failure. and changes that happen over time and are age-related generally. And it's obviously more common amongst adults or older adults, but can occur earlier in life, and it is associated with other conditions such as early dementia, diabetes, kidney disease.
And we will, Anne-Marie will go into the importance of strength training as we move through this. So gait balance and frailty.
The gait balance and frailty is a significant contributing factor. Muscle weakness, our gait speed and cadence tends to slow as we get older. Poorer balance generally, not always, but and a lot of these risk factors we can actually have good input, effective input into helping to negate some of them.
Yep. And a huge part of this physical function impairment comes from the effects of hypertension on the body. So we will move to hypertension as obviously the cardiovascular, one of those cardiovascular effects.
The hypertension seems to, according to the literature, have one of the biggest effects, as Helen said, on falls. It affects many of the different systems within the body, brain, and most of you will know many of these aneurysms, dementia. So that's the dementia can be vascular dementia, which is an early onset dementia, often memory and understanding, again, related to the dementia and vascular changes, stroke, TIAs, and other microvascular events, changes in vision, blurry and loss of vision, again, microvascular events within the eye, within the optic nerve, choroidopathy, retinopathy, optic nerve neuropathies, vestibular. I found some research to suggest that some links to cochlear dysfunction and vestibular dysfunction contribute to falls, although they're not strong links at this point, but there's a lot of research being done
around
in
balance.
that area.
Yeah.
For balance.
Yeah.
Ventricular hypertrophy, the enlarged left ventricle, the association with arrhythmias and heart failure. Chest pain, again, those cardiogenic factors, the unstable angina, heart attacks or MIs, and chest pain, APO, the breathlessness that can be associated with chest pain, which comes back to the corpulmonale and right-sided heart failure as well. Renal impairments, kidney disease, the AKF, arterial damage, atherosclerosis, sexual dysfunction, men, erectile dysfunction, and women, vaginal dryness and lowered libidos. Osteoporosis causes the body to eliminate more calcium, decreasing the availability to calcium channels for muscles and osteoblastic and osteoclastic activities. Increased sympathetic outflow, cytokinins, and the effects of the angiotensins 2s, as well as the oxidative stresses. Abdominal pain can be aortic distensions and dissections in some cases, obviously worst case scenarios. Continence, the heart failure, the medications, the diuretics, urinary frequency leading to urgency, which lead to the falls, increasing the falls risk, both the balance, vestibular, increased risk and poor outcomes for women with hypertension over 60 for the hip and knob fractures, social isolation and dehydration. And dehydration is a risk all on its own because of the headaches, the dizziness, impaired kidney function, and intestinal failures.
Yeah, so hypertension and its effects play a massive part in these cardiovascular risks linked with the falls risk. And using the American Heart Association's diagram, also orthostatic hypotension, non-arrhythmic cardiac syncope, and arrhythmic cardiac syncope all play a huge part. So the traditional cardiovascular risk factors, all those comorbidities play into this. So Anne-Marie's spoken about the high blood pressure effects, of course, high cholesterol too, the diabetes, the microvascular disease, being overweight, being underweight. Being overweight can affect your risk of falling, being physically inactive, having that unhealthy diet, tobacco smoking, and depression, anxiety, and social isolation are of themselves cardiovascular risk factors, and therefore that means they are also a risk factor for falling. So syncope, of course, is fainting, decrease in blood flow to the brain that results in that loss of consciousness and subsequent fall. So there's lots of literature on this, so please go out and find that. But heart arrhythmias and then that lack of oxygen, lack of nutrients, to everywhere in the body, but to the brain, can result in that fall. Orthostatic hypertension, where that blood pressure drops quickly. We especially see this in older people because livers and kidneys can't excrete the medications. So really important that we get people a medication review to ensure they're on the right doses of all their beta blockers, their ACEs, all their heart failure drugs, etc. And other drugs as well. So it's not just that, it's drugs they take for all kinds of conditions. So heart failure, of course, that exercise intolerance, respiratory symptoms, less blood flow, there can be some reduced cognitive function, fluid retention can affect your balance. When your feet are really swollen, you're walking, your gait is off, and your ability to walk well is reduced. Your ability to even see the trip hazards around you is reduced. And of course, heart failure and its links with depression and anxiety are well known. Nothing works without mind, body, and spirit. Every condition we have affects us in that way. So again, the medications, drowsiness, dizziness.
The unsteadiness, especially medications for pain medications, tramadol's probably one that comes to mind. Blurred and doubled vision, microvascular events. Again, in the optic system, confusion can be either on the medications or those other causes that we've already discussed.
Yep. And many of these medications that people are on, they do affect their cognition. Pain relief, tramadol's a classic because I wouldn't be able to count the number of people I've looked after with tramadol who actually changed in a moment. Cardiovascular risk factors around that non-arrhythmic cardiac syncope, we have to think of women too. So women don't have those classic signs of an elephant sitting on their chest and, dramatically fall with a MI. They often have that dizziness, that fatigue, that nausea. And so we have to think of them in that sense that, yes, they will fall. if they don't seek help early. So we always get the message out about women's hearts and the warning signs of a heart attack and how they're different for women.
And the women are the ones that will probably put it aside a little bit longer than men, which is why we see a higher rate of fatalities within the women's cohort.
It's true.
Because we put it's just a dizzy spell, or I'm just feeling unwell, or I'll sit, I'll have a drink of water, I'll wait for an hour, things are happening around me.
Yes.
The social responsibilities, especially within the Aboriginal women, of not being able to get to medical help, and rural and remoteness. There's not always a medical facility available close at hand, so they tend to put it off a bit longer.
Yeah, and you know, we need different ways for different people, because it's all very well to say to people who are close to a hospital, don't drive yourself, or don't have a family member drive you, call the ambulance, but that isn't always what can happen for some people. So we have to always remember that individualized care for everyone.
And the resources available to people within the smaller communities and rural and remotely.
Yeah, definitely. And I mean, we have women that think they go and need their teeth checked because they have jaw pain. So it's these kind of messages that we need to get across. So cardiovascular risk factors around those abnormal heart rhythms are, of course, long QT, Brugada syndrome, and Wolff-Parkinson-White syndrome. But we don't need these sudden and these dramatic rhythm problems that people fall suddenly. AF can impair the ability of the heart to pump, and especially to the brain, and that lack of oxygen can make people feel faint and possibly black out, or have that dizziness that makes them unstable and then they fall. And of course, if in a heart attack, so in a myocardial infarction, it may well be that asystole, VT, and VF play a part in that sudden fall. But bad enough to have the heart attack, you don't want to also then have a brain injury. So seek help early wherever possible. So sleep is a massive risk factor, and one of my colleagues, Tracy, at Hollywood, you know, when she shows people a risk factor wheel, she always puts those psychosocial and sleep and the effects it has on each risk factor as part of that, because that sleep fragmentation and that tiredness, and I'm not thinking straight, I'm tripping over things, I'm bumping into things, I just needed more sleep. Sleep in itself is a risk of falling, but the use of sedatives again are another risk of falling.
And that's increased with things like nutrition during the night, when if they've had a sedative, getting up under the influence, I guess, for lack of better words, and the fall that can that is related to that. Some of the cardiovascular medications will also make you very sleepy. Metoclopramide for the nausea can also make people very, very sleepy, increasing again the risk of falls during the night.
Oh, sorry, I just saw the chat. My apologies. Oh, I'll just click on it. Yeah, we've just noticed, sorry, we didn't have the chat on the side for us. So we might have a quick look at this while we're here. Thank you. Okay. Okay, it's more comments than, but please put your questions in the chat and we will answer them as we go. So we've already spoken around the link between depression and falls, but so it's this cycle and this circle of, I have a chronic illness and therefore I have low mood or clinically diagnosed depression. Then I have a fear of all sorts of things, but of falling, of the fact that I don't feel as sharp cognitively as I used to. My sleep's impaired. Is it because of my depression, or is it because of my cardiovascular disease, or is it because of the medications I'm on? Is it because of my heart failure? I've got to get up and down to the toilet. So now I'm having more falls. And this cycle, then I've got more injuries, I've got more comorbidities, and round it goes, I become more depressed. So there's a massive link here. So the more we can help people to avoid falls, the better. So we spoke earlier about those social determinants of health, like poverty and overcrowding, etc. And, you know, maybe not prioritizing. Aboriginal people prioritize family first, not self. So Anne-Marie spoke to like mothers that would say, no, I've got chest pain, got to get the kids to school, got to do this, got to do the shopping. It's not always the priority. So to treat Aboriginal people well, we need to make sure we look after all those holistic aspects of their care and are acknowledge that it's not just physical care we need to give, it's psychological, emotional, social, cultural, and we have to ensure that we look after all those aspects, because if we want to treat someone equally, we have to be prepared to treat them differently. And we have to be prepared to come from a social and emotional well-being model, as opposed to from our Western biomedical model. We have to yarn with people. So I'm not sure who's aware of Don Besser's model of clinical yarning, but we start by having a social yarn. So it would be, where are you from? How you going? Lots of listening, and then move into that diagnostic yarn. So what's been happening with you, and just in that conversation, pulling out what's going on, and then the management yarn about how we can help these people in a way that's going to work for them. Did you want to add, Anne-Marie?
I think that being aware that we do need to connect more with country for the Aboriginal people, and just being knowing that they have different priorities, knowing that they have different circumstances, and again, a significant population that we receive in Perth especially is can be flown in from other places, which means that they are socially isolated. They don't actually want to be here. They're here because they've presented to a smaller regional site that just can't give them the best care that they need, and they've been shipped away from family. So understanding that those determinants as
play a big part,
they play a huge part.
And to find an Aboriginal person, or even to wear something on your uniform that says, like the flags behind us, that says I care about Aboriginal people, can be just that first link in. So really simple things can help. So we're going to speak a bit about screening tools and prevention strategies. So screening tools for falls.
There are so many different ones out there. We have gold standard ones and all the way down to ones that just get used because they've been used forever. Historical tools are still out there. That doesn't mean that they're not good. It just means that some of them don't have the evidence that some of the others, like the timed up and go that we tend to use, have. We use different tools in different settings, whether it be community, primary care, hospitals, residential aged care. We've got the falls risks for older people, the FROPs for the community. Timed up and go is definitely well, I know that the physios would all be very familiar with the tug, the sit and stand, the Berg balance, and the cognitive screening tools. We tend to use those initially, probably clinically acute settings, so we can use them in the ED or on the wards.
Yep.
And it's also important to recognise that the screening tools is not a falls prevention intervention. It's a tool just to determine your risk.
Yep. And of course, injury matters. And APU, the falls screening and assessment tools are available on the Injury Matters website. So please check these out. Other screening tools before we move on would be things like PHQ-2 and 9 to look at depression, and the GAD scores to look at anxiety. So there are many tools you might use, tools that are particular to your service that you've discussed with the multidisciplinary team and see as the best tools to use in your service. Yeah, and RACGP have guidelines too.
Everybody has guidelines. There are so many guidelines out there for this, but we found that the RACGP are very readily accessible. They're downloadable very quickly. They're not huge and they're not onerous. So they're probably ones that we tend to use a fair bit.
Yep.
So identifying the risks, there are two simple tests. The repeated, the sit to stand or chair standing test. It was in some of the literature. How quickly your patient or client can go from a sitting position to standing position 5 times without using their arms. More than 12 seconds indicates an increased falls risk, and some are just not able to get up from the chair at all without using their arms. There are modified versions of that, but generally if they have to use their arms, they are at a higher falls risk because they have weaker quads, abdominals, glutes, hamstrings, lower limb muscle groups are not as strong as they could be.
Yes.
Yeah. The alternate step test, how quickly you can alternate steps. Please do this in a safe setting. Have a rail, have a bench, don't do it out in the middle of the hallway where there's nothing to grab. We've certainly had students over the years do it out in the middle of the room where there was nothing there and it's ended badly. So more than 10 seconds indicates an increased falls risk. So do it somewhere, obviously check your safety. And if you are suspicious that they can't step up an 18 centimetre height, then progress it. Can they do a hob 5, a 10 centimetre, and then check to see if they can do an 18 centimetres. 18 centimetres is really quite big for somebody that doesn't have good lower limb strength.
Yep.
And there are lots of other tools out there, the quick screen assessments and tools, and the injury management organisation, the Stay on Your Feet Fall screening and assessment tools. Jo has just put up on your chat for you as well.
Fantastic. My husband I can attest to the weakness in his legs by using his back and his shoulders to get out of chairs for years, and not helpful for his back pain, but he's relearning everything, which is great. So good on you. Exercise people in the room, fantastic. So we're just looking around. How do we look after people? We really must have that person-centered approach, where we look at what's valuable to the person, what matters to them.
And their families.
Yes, what matters to them, not what matters to us, because that's how we hook them in. And then we can be able to give them messages that they can build on to make sure that care is correct for them. And we need to use a trauma-informed healing approach. And that means not coming from any sense of what's wrong with you. It's what happened to you. And when we use that language, we truly get to what has happened to someone and their suffering. And then we can link in and engage and see what their values are and use the whole multidisciplinary team. Of course, that doesn't always exist in rural and remote, but wherever possible, use as many people as we can to link in and help and be a partner in care. We no longer do to people, we do with people. We don't do for either, we do with people, because they're the expert in themselves, and then they learn the best ways to care for their cardiac health and their falls risk. Yep. Good. I get a bit preachy around all that stuff. I can't help it. So falls and cardiac health prevention strategies are, of course, that education, person-centered care, some training, that can be personal too. Attending your programs, you may have cardiac rehab programs, you may have falls programs, you may have all sorts of different programs that they can attend. And then also using tools that they can use themselves, creating those safer environments. It might be that you need the OT to go in and have a look at the home and see what's required there. That self-confidence we saw with the depression cycle, that you really need to tap into making people feel confident. Behavior changes around, if you do something and you are given praise, you'll do it again. So to increase someone's confidence is to say, fantastic, you got up the chair, off the chair there without using your back and your shoulders. Well done, let's do, they'll do it again because of that positive reinforcement. So it's really important to increase self-confidence, and that social and emotional well-being can't be understated. Pull families in, pull the kids in, all those values, that family is the biggest value for most people. And, you pull that in to help with strategies. It might be that you have patients that want to see the randomized controlled trials around why they're falling. That's fantastic. We have to have different ways for different people. And we need to know what the research is and what's new. And we need to keep up to the minute so that we can care the best we can. And having those effective policies around risk and risk management in your services.
Going back to the training, that can be all sorts of training. It doesn't have to be one-on-one. It can be in groups. It can be in community centres. It can be a stay on your feet. any movement really is going to help with the risk of reducing falls, and getting people moving. Hydro classes, walk the dog groups, church groups that may request. We've had a church group down south that they wanted the physio to come in, and we talked about just getting a little group together, and they wanted to know what sort of exercises were safe to do. So we went through a few things, and the ladies started off just being ladies, would get together for half an hour after they'd or before they'd done service on whatever day, Saturdays or Sundays or whenever they did it. And they then started at a couple of other days during week. They had a craft group, and they would do a half an hour of exercise.
Yep.
Little weights.
Because the social and those emotional benefits around being part of a group, yeah, they are fabulous, really great. And then, of course, there might be people who prefer, we have personal walking plans within the Heart Foundation that were developed during COVID when people couldn't be in community groups. So there are things that we can use for other people who prefer that more solitude around their walking, and yeah, so
or don't have access to group living out of town, or more remotely. Not everybody has access to, especially in the older age group, don't necessarily have access to vehicles. They rely on family members, especially to get them in and out to different appointments and things. So they're not always going to have transport into town for a meet up with groups.
Yeah, so we've got to have something for everyone. But I guess the big thing is to start by knowing your risk of heart disease. And we have lots of tools at the Heart Foundation. If anybody's got their phone, they can scan that heart age calculator. And of course, it works out. It takes 2 minutes. And then if you have high blood pressure, if you're obese, if you don't exercise, it will ask you all those questions. And then, you know, if your age was 40, if you have a few risk factors, it might bring your age out as 48. And it's a motivational tool. It doesn't work really well for Aboriginal people, is the feedback that I've just heard from Aboriginal people. However, it does work well for many of us to just be that next step to go and have a heart check. So a heart health check is free for people over the age of 45. Thanks, Joe, for posting that. And for Aboriginal and Torres Strait Islanders over 30. So the GPs can have this as part of their software, and it's a free check, the MBS item number.
Heart disease is the leading cause of death.
We won't show you the video now, but you can check that on our website if you wanted to have a look. So we're going to look now at how, by protecting your heart, you also protect your risk of the link between cardiovascular disease and falling. So a heart attack is a medical emergency, and we have many, we have Aboriginal animated videos up on the website. We have lots of resources, these fridge magnets we have for people to make sure they get help quickly. I'm just going to show you a video around heart attacks and angina.
For your heart to function properly, it needs good blood supply. The coronary arteries are small tubes that supply blood to the heart. Over time, and with certain risk factors, blood can build up in the walls of the artery. This is called coronary heart disease. Plaque is made of fat, cholesterol, and other materials. As more plaque accumulates in the artery walls, narrowing can occur, which reduces the amount of blood flow to your heart muscle. Sometimes your heart needs to work harder than usual, such as during physical exertion, emotional stress, or after a heavy meal. During these times, your heart needs more oxygen-rich blood than the narrowed arteries can deliver. When there is a lack of oxygen to your heart muscle, you may experience angina. Angina is a feeling of pain or discomfort that may feel like heaviness, pressure, tightness, or squeezing in your chest. Angina is short-lasting and goes away when the demand on the heart is reduced by resting or angina medications. Coronary heart disease can also lead to a heart attack. A heart attack occurs when the artery wall tears or ruptures and the bloodstream makes contact with the fatty plaque that was inside the artery wall. This can cause a clot to form, which may block the flow of blood to the heart. A blocked artery can damage the heart muscle, and urgent treatment is required to restore the flow of blood to the heart. A heart attack is a medical emergency. Unlike angina, the signs of a heart attack will not go away with rest or angina medications. In a heart attack, urgent treatment is required to clear the blocked artery and save the heart muscle from permanent damage. If you think you are having a heart attack, call 000.
So at the Heart Foundation, we have these resources. Please get on our website and use these. I think that's a great video to show to your patients around the difference between the heart attack and angina, and to help them understand why they have to carry their GTN spray, etc. And then they might not risk a fall from having a heart attack. And yeah, just remind them to sit down while they take it. So we have many resources on the Heart Foundation website, but protection is best. So we have check your age with the heart age calculator, have a heart health check, make sure you know the warning signs, and then these 5 simple steps to make sure you can be the best you can be. Step 1 is around eating a healthy diet. Step 2 is more being active. And like Anne-Marie said earlier, that's movement. It doesn't mean you're going to run in a marathon. It's movement. It's move more, sit less. Be smoke-free. Understand your cholesterol levels, your individual ones, and understand and control your blood pressure. And we're just going to talk through all these simple steps. So the importance of good nutrition can't be. So we really would like you to pop in the chat, what does a healthy diet look like? Just put some foods you think are healthy in the chat there. Anything at all you can think of. Just type in the chat for us. And we'll just, yep, fruit's great, eat more greens, fruits, vegetables, grains, plant-based vegetables, whole grains. Yep, we're on the money. Yeah, maybe a bit about, how about portion sizes? Anybody got a Mediterranean diet, moderation of all groups? Healthy fats, protein, so it's all happening. It's great. I love it. Protein, water. I'm liking the water got in there. A balanced diet, not limiting, but a variety. Love that. Thank you, guys. That's fabulous. So we'll just have a look at, so Heart Foundation no longer. So this is why I've maybe put that. We don't. In fact, the word diet is it's about nutrition. It's about those healthy eating patterns. So we're saying picture number 1, eat most of that. Picture number 2, yep, great. Picture number 3, yeah, maybe not just as much. Picture number 4, healthy fats. Yeah, picture number 5, add those herbs and spices. So like you've all said, you've covered all these food groups, but the link between the diet and the healthy heart is really clear. And eating these healthy foods that you've all mentioned there is really important to lower your risk of heart disease.
And the other links with the nutrition is managing salt intake and the cholesterol, as Helen's talking about now. So cheeses and high fat food.
Patients, again, aiming for those 5 serves of vegetables a day. A lot of patients may be actually achieving 2 serves of fruit per day, but most commonly we find that most people do not do the vegetables per day. They're having enough vegetables per day. So a reminder to add them into vegetables and salads and soups and casseroles and to try them as a snack.
Yep.
Go for the grain, replacing your white bread and your white pasta with whole grain, seeded bread, brown rice, high fibre breakfast cereals.
Perfect.
Eat more legumes like lentils and chickpeas and beans. Use dried and cooked or canned varieties, either alone or add into a dish to reduce the amount of meat. So again, it's outcrowding the things that we'd like to limit. Aim for 2 to 3 serves of fish per week. And canned fish in spring water or olive oil is best. It's convenient, it's cheap, and it's easy to include in your lunch. Try introducing at least 1 meat-free day per week, and don't forget to check out the Heart Foundation recipe.
Yeah, and there's lots of Heart Foundation.
Touch on our new
sorry.
Statements.
Oh,
Helen, I think that's coming from your laptop.
I think it is.
Okay.
So I'm just going to show you the video. It was Sandy, though, which is fabulous. Sandy works at Injury Matters.
She does.
So it's great. I love it. I thought she was actually talking for real, but it's all good. So what does a healthy plate look like? It's classic.
It's like coming on like on here. I'm like,
Oh, that's funny.
that was really funny.
I think the video's on a loop, Helen.
Making me hungry. So that's just a really good way to show your patient ways that they might make up a meal. Yeah, a really cute, cool little video to do that. So, yep. Yeah, I find that really helpful, and everything looks really yummy afterwards. And we have lots of Heart Foundation recipes that you can just scan the barcodes on them, and then you can make these at home, and you know, you can download if you want and print the barcodes for your patients, whatever works best. So when we think about diet, we have to think about the drinks within that. And thank you to the person who popped water in there. Really important we keep that hydration okay. And alcohol, of course, is a risk factor for falling, and too much of it is a risk factor for heart health. So we want to make sure that we say 10 standard drinks per week, but we don't want them all on one night. So no more than 4 in any one day. We're not recommending that. If you don't drink, then stay that way. That's great. And pregnant women, there's no safe level of drinking. So next question is, step 2 in looking after your heart is to spend more time being active. What are the benefits and how can we help people to be more active? If you can pop some ideas in the chat again, that would be fantastic. So exercise and being active will help your risk of falls as well. Oh, definitely. We're shifting endorphins, aren't we, Pooh? We're shifting endorphins, we're shifting off oxytocin. So the effects we're getting out in the air, we might be going with people. So huge. And yeah, definitely park a bit further away and walk is a great thing. And yeah, I often make sure I've got 2 or 3 parking spots. So that's a definite. Then I can park easy and walk. So it works for lots of things. No stress about getting in a tight spot. Get the dog out. Oh, yeah, I miss my dog so much.
Let's go dance.
Yeah, let's go dance. Let's all get up and dance for a minute. And wherever you are, get up and dance, because we've been a long time inactive here. So please get up and dance. Get in the garden. Lovely. I love gardening. Beautiful. Have some active aging advocates. Yes. And go with someone. So after you've had a heart attack, you know, you might be given a program, but the first couple of times you go out, make sure you go with someone, because you need to get your confidence. So again, it's that mental health linking into the physical health. Zumba, oh yeah, well, we might manage that, would be great. Yoga, the benefits of yoga, Tai Chi, lots of different exercise. I don't think exercise is medicine, isn't it? Movement is medicine. That's the one. So any kind of movement. And if you are, you know, constricted to a chair, any kind of movement is great. So thank you guys for getting involved. So the other thing we really need to talk about here is, we alluded to it when Anne-Marie spoke to sarcopenia, etc. So is the strength training. Yep.
Physical activity recommendations for adults at the moment, 30 minutes of moderate intensity on 5 or more days a week. That's a huff and puff. So they still need to be able to whistle or talk. Walk and talk is sometimes referred to. It can't be intensity that doesn't allow them to be able to engage in a conversation or hum a tune. That's just too much. Moderate intensity is safe, and more people are much more likely to do it if they're not feeling like they are being suffocated or pushed past the point of being comfortable while they're exercising. Being active on most days of the week, at least 5, some muscle strengthening activities on at least 2. So the muscle strengthening activities can be using TheraBands, they can be using isometrics, so body weight, wall push-ups. It doesn't, not talking about doing sit-ups or anything like that. I'm hoping that nobody is prescribing sit-ups anymore, especially for older people. They tend to hold their breath, which is not good for cardiac function and backs and stomachs and hernias, all sorts of things. So the strengthening activities can be even walking through water, hydrotherapy, using any kind of other resistance is going to work. And again, just get them moving to start with. After that, you can build on it for sure.
And I think just a short little story. Yesterday morning, I arrived at work, and there's a group here in Subiaco that go for a run prior to their gym class. So I found this middle-aged gentleman bent over, coughing so badly he was about to vomit, sweating profusely. And I told him, I have a defib and I'm not afraid to use it, and you're exercising far too much for your capabilities at this moment in time. It might be that it's early in the morning. It was only 7:30. He maybe just got up, ran, got to his exercise class. And, you know, so he was false risk waiting to happen out there. And yeah, or an MI or worse. But anyway, it's also, you know, you're not a hero in that moment. And yes, so I sat him down, got him some water, and he became better. But yeah, we have to be careful with the people that want to run before they can just take on the gentle walking. Yeah.
And it is important to make it enjoyable for them, and whatever that means. If they don't, you know, some people are not runners, some people are not swimmers. Choose whatever works for them. If it happens to be roller skating, then that's fabulous too.
That's great. Yeah, just that getting out in the air is fabulous. So we do have downloadable resources where people can do their exercises at home. We do have Heart Foundation walking groups, and people can form their own. And these are a great thing in the country as well. So your group you were speaking about, I was like, well, they could be a Heart Foundation walking group. And then they get a lot of the sort of risk management and have a walk leader and some helpful resources, etc. But that's definitely something. And the personal walking plans we spoke about also are a great way. And you receive motivational text messages on your phone, you know, that would say, oh, have you been for your walk today? And the benefits of walking are. And so it's a good little motivational tool. So next question for everybody. What's the benefits of being smoke-free, or how can we help others be smoke-free? You're most welcome to answer either of these and put your ideas in the chat. Thank you. I think the benefits of being smoke-free probably goes without saying.
I hope so.
Yes. And a big thing we need to think of as you're thinking of your answers is around the vaping that we see rearing its ugly head these days. So Quitline is fabulous, great resource, education and support. Saving money, yeah, great idea, great motivational tool to use the saving of the money as a part of your motivation. Vaping should be banned. I think we're all in agreement on that one. Yeah, I love it. Thanks, Diana. Talk to your GP about options and supports. And from my years of experience with people and smoking and heart disease, it was always about engaging with the patients at that point they're at. I always remember a gentleman that lived in a country area from Royal Perth. And I said, oh, will you be happy if I give you some calls to help you, keep your heart healthy? And he said, as long as you don't talk about smoking. So I said, fine. I put a great big pink post-it note on his records and said, don't talk about smoking. So I was about my third phone call with him, and he went, Helen, you haven't asked me. I said, I haven't asked you what? He said, you haven't asked me about my smoking. I said, you said not to. He said, I gave up. And so because I'd worked with him, and we got his cholesterol down, we got his blood pressure down, we got him to exercise more, do everything, he trusted me now. So he said, oh, well, I'll go out and I'll do this myself. So we have to remember people are the expert in themselves, and they will do these things. You just have to make sure they trust you and that you work with them and listen to them. So yes, definitely. Who was it, Diana? Yeah, we don't even know what is in the vaping products. So definitely this is something we have to recommend people quit. And of course, Quitline resources are all there.
Different organisations can have support groups and resources available within the organisation as well. Some of the organisations that I've worked with in the past provide patches or gum. They will provide within their health team referrals to GPs or specialists, including psychologists, to help with the habits and to break some of those ongoing reasons, I guess, that people believe that they're smoking, and bring in some strategies for them to help them manage their addiction.
Yeah, and with motivational interviewing tools and teach back tools, etc. I mean, the basis is that active listening. Listen, find that discrepancy. I used to use tools like a balance sheet where I would get people to write down, this is my reasons to stay smoking, and this is my reasons to stop smoking. Then you could have that conversation. Oh, actually, you think it relaxes you? There's no evidence around that. So if you stop smoking, you could get out with the grandkids, you could get on the soccer pitch, and you could kick the ball with your grandson, etc., etc. So you're actually eliciting from them their reasons to stop. It's nothing to do with you. It's their values that come through, and that's what you're linking with.
It certainly becomes a negotiation rather than a lecture.
Absolutely. We never would, never. You can give people information, and that's fine, but never the minute you tell someone what to do, most people go, yes, don't tell me what to do. And that's just human nature.
Work with and not.
Yes. So now, guys, next question is, we want people to understand and control their cholesterol levels. So what should cholesterol levels be? And what are some of the tools we might use to help other people understand why they need to lower their cholesterol? So the big important message around cholesterol is, reduce unhealthy fats, perfect, is LDL should be less, LDL, which is bad cholesterol, less than 1.4. So you find the starting point. So if you find someone with LDL of 3.8, You're not going to say to them, you've got to get it to 1.4. So anything lower than the starting point is, and to aim for 1.4. Because sometimes we set people up for failure. So we want them to reduce their cholesterol, their LDL. And in doing that, they don't need to, because people get all confused, total cholesterol, HDL, this LDL, everything. Focus on getting the LDL down. And people can understand that. The low density lipids are what's causing the fat to sit around my heart. So I'm going to show you another little video which is helpful for patients again.
Substance that is important for metabolism.
Sorry, Helen, we can't hear the video.
Chances of a heart attack or stroke. HDL cholesterol, or good cholesterol, carries LDL cholesterol away from the arteries and back to the liver to be broken down and passed as waste. Known as the silent killer, high cholesterol generally does not have obvious symptoms, which is why it is extremely important that you visit your doctor regularly for checkups, even if you are feeling well and healthy. While there is no single cause for high cholesterol, there are risk factors that can contribute to the condition. These include age, smoking, lack of physical activity, obesity or being overweight, family history, and an unhealthy diet. Most of these risk factors for heart disease can be managed by making lifestyle changes such as improving your diet, exercising more, and quitting smoking. Your doctor may also recommend certain medications to help lower and manage your cholesterol levels. If you are 45 or older, or from 30 for Aboriginal or Torres Strait Islander peoples, see your doctor for a cholesterol test as part of a heart health check. And if you have a family history of premature heart disease or high cholesterol, you should speak to your doctor about your heart health earlier.
Hey, so again, just bringing it back to that fact that people can go and have this, it's free. You get blood pressure, cholesterol, you get all your assessment done in a heart health
Heart
check.
disease is the leading.
But I don't think we've got time to show that, so you can check it on the website. So next thing is understand and control your blood pressure. So what should your blood pressure levels be, and how can we help people? Thinking back to Anne-Marie's effects of hypertension, how can we help others understand the importance of controlling their blood pressure levels? Takes a minute for messages to come up. So we'll give it a minute. Yeah, 120/80, good starting point, great. Yeah, give it a minute. So the WHO guidelines say that hypertension and non-cardiovascular disease of greater than 130 is systolic. What we know here is that once we start people on beta blockers, ACE inhibitors, lots of blood pressure medications, after a STEMI, 90 on 60, even 50 can be fine for that person. So again, it comes back to this person-centered care and this individual holistic care. But yes, as a guideline, 120/80 is great. I'll show you a graphic on the next page, which I think is really good for patients. Is in the middle, there's that graphic that shows if it's getting a bit low, oh, okay, what can I do about that? Ideal is that 120/80, it's in there. You know, I better watch out 130/90, and that diastolic over 80 is where we're starting to get cortisol shift and damage happening to the cells. So, and definitely when we get to 140/90, we got to be off to the GP.
I think it's about knowing or encouraging your patients and clients to know what is their normal. As Helen said, it can be different for everybody. And yes, we want them to be within our norms, but we need them to know what is their normal and to take a bit of an interest in where their numbers are. Ask the GP when it's being done. Don't just say, the GP will sometimes say, oh, it's fine.
It's fine. Yep.
What does that actually mean? What does that mean to that person? And if it's, you know, the GP's just taken it randomly, it's a bit high, then sometimes that happens. If it's a bit low, but it could be that they run low most of the time, and then it's high on that particular day and they're feeling symptomatic with it. That then needs to be noted rather than just being it's still fine. If it's too high for that person on that day, then it still needs some action taken.
So you need to know your numbers, and you need to know the symptoms around when your blood pressure may be too high or too low. And APO's put around managing salt intake. So as we take salt in, if we take too much, we can cause that increase in fluid retention and therefore in blood pressure. So we especially have to be careful in people with heart failure who've been diagnosed with their left ventricle having a reduced ejection fraction.
And the other one is dehydration, as we spoke about before, not having enough fluid on board.
Yes.
And the consequences of that.
Yes, because that plays big into falls. And we have tools here where you can get people to measure their own blood pressure, because we do. There is always that, you know, that white coat can play a part in people's anxiety and going to the doctor. Depression and anxiety are so common in people with heart conditions, but we've also learned today they're really common and are a massive risk for falls. And so we need to just use a simple tool like these faces to say, let's talk through your emotions. How are you going today? If you're not comfortable with just sitting, then use a, you know, any of these wee faces. Do they resonate with you? I feel angry. Why did I have a heart attack? I'm only 40. I do everything right. Oh, yeah. Okay, well, let's look at that. Yes, you actually have familial hypercholesterolemia. Let's, you know, work through why you feel so. I thought I was going to feel so guilty. I thought my family were going to be left without me, etc. So use that. And just going back to the chat for a minute, Kim's asked, or not asked, told us in the older demographic, how high is too high in regards to the diastolic in exercise. For example, to do a 6-minute walk test after taking a resting blood pressure. So resting blood pressure, do your 6-minute walk test. How high is too high while I do that?
For diastolic, from what I've read, it should be no more than 10% higher after they've been exercising. So if they start at 75 or 80, it shouldn't go up more than sort of that 90.
Yeah.
And if anybody was between 90 and 100 for me, I would be sitting them right down and with some water, rest, and monitor very closely just to make sure that they're not having an adverse event, and then push the oh my gosh button if you need to, and get some more medical help on hand if you need to.
Yep. Kim, does that answer your question? It's also around looking at other signs and symptoms. Is this person now, are they sweating? Do they feel dizzy? Do they feel nauseated? Do they, what's going on here? Oh, is it that they're dehydrated? Is it? So again, it's all that clinical stuff that you would be doing. So, and again, it is that individualized. If you know someone's going to start with a diastolic at 90 and every week they come, it does go a bit higher, but they quickly get back to normal, then you learn how to work with that person.
It's definitely about looking at your clinical picture. Are they symptomatic? And have a cutoff point in your own head. If you don't have immediate medical help at hand, don't go so high.
Yeah. And it might be, yes, if you're in a tertiary centre and I've got all these other people around me. But if you're out on your own somewhere, you definitely would not be pushing anyone. You would just be saying, let's try another day. Let's see what's going to happen, settle down. So again, that individualized care. So with mental health and cardiovascular diseases, and we saw with that graphic, the risk of depression and falling is huge. And it's that big circle of I've fallen now, that leads into depression, that leads into comorbidities, leads back to depression. So early diagnosis is important. Screen people. Social isolation and loneliness is a cardiovascular risk factor, and it is a risk factor for falling because you now aren't as active. You don't have that motivation and determination to get up and do things. So we need to raise awareness of this link. Yeah. So resources wise, we have programs for people who have heart attacks and angina. That's called the My Heart, My Life program. Friends and family are encouraged to attend. They're given booklets in hospital, follow-up booklets, access to up-to-date information. They can get on a Facebook group, which is actually a really great support, because then it's a peer support and it's people who have that lived experience, regular emails, etc. So, and you just go on and register as a patient, a support person, or you can register your service. Our cardiac rehab directory is not just for cardiac rehab. Heart failure services are listed there, and any cardiovascular atrial fibrillation, other cardiovascular problems, you can join a group. We have resources for people in different languages, and around different subjects. So we have them up on our website, and so you can print these off in numerous different languages, depending who's in front of your email your patient the information. We have a series of heart failure videos that are also in different languages. So please get your patients to check them out because they're great. I have spoken to Heart Foundation Walking and personal walking plans, but please use these and get involved. So in the PowerPoint today, I've put lots of resources and you will be sent this after, but you just get on the Heart Foundation website and you can basically order 50 of any resource for free. So please do that and have them in your waiting rooms, etc., or send people to the online resources too. Oh, we've got half an hour. I thought this video is around people in hospital and the effects of not exercising. Is it going to come? Good. Oh. I don't know if anybody's heard of PJ paralysis. It didn't take me to the video. This is the website and this is the video.
If you had 1,000 days left, how many of them would you want to spend in hospital? The fact is, however well-intentioned, however hard we try, patients still get stuck in our hospital systems every single day. If we can just get one more patient every day, up, dressed and moving, we're making a difference. We're getting those people home to their loved ones. We're improving their quality of life and we're giving them back some control and some dignity. That's why NPJ paralysis matters. When we talk about time, we're genuinely well-intentioned. We're genuinely talking about valuing patients' time, but our actions don't always follow that through. Actually, what we do is we talk about clinicians' time. We value doctors' time, therapist time, pharmaceutical time. We don't put our patients right in the centre of it, and that's why NPJ paralysis matters. Simply put, NPJ paralysis is about making patients' time the most important currency in healthcare. It's about getting people up, dressed and moving and home.
Why the 70-day NPJ paralysis challenge? The NHS is 70 this year, and our goal is to get 1 million patient stays of people up and dressed and moving. Why? Because we know every day people are deconditioning while in hospital, and that causes real harm. What we're looking to do is get people up, dressed and moving while in hospital. How do you go about doing it? Well, you download the app, you register, and every day for that time, you, your colleagues on each ward, across the country, across all specialties, across all ages, will just answer 2 questions. How many patients are up and dressed in day clothes? And of these patients, how many of them are mobilizing to the toilets, to the shower, even around the bed? It starts on the 17th of April. It finishes on the 26th of June. We're going to get together, going to have 1 million patient days of people up, dressed and moving. And together, we will end PJ paralysis.
So just to show there are some great initiatives happening out there, and hang on, where am I now? I've lost my slides. I need to escape from that. Don't know. Go there. No, don't go there. No, close. That's the one. Oh, didn't close. Excuse me, we've been going well, and now
Helen, try the escape button.
That's the one. That was easy. Okay. We were going well till then. Yeah. So it's about, so that deconditioning can happen. So it's about the prevention, people not getting to the point of being in hospital. So, but even when they are in hospital, let's get them out their PJs and get them moving. Yep. There are many different sites you can go to. This one, Safe Exercise at Home. There are rehab programs like CardiHab or the coach program for HBF patients, as well as the cardiac rehab directory to get your patients involved in exercise and staying out of hospital. Are we on full screen?
We
Yeah,
can
I
see
think-
your bar at the bottom.
Oh, okay. Okay.
Yeah.
Yep.
Is that it? That's better. Yay. Good. Okay. So, you know, you also have to think that you link with the national safety and quality standards by looking after your consumers and protecting them from harm. And the aged care standards as well, preventing falls and harm from falls, especially in older people. There are best practice guidelines for this. So we really, we thank you for inviting us, APU, and we are really happy to take any questions at all.
Yeah, so if you have any questions for Helen or Anne-Marie, please put them in the Q&A box and we'll take questions now. I feel like there were quite a few questions throughout the conversation that you have answered. So, but it was really lovely to kind of see the same. There's so many risk factors that are so similar for cardiac health and falls, and it was lovely that you guys mentioned sleep as one of them. I think we all forget that that is a very important risk factor, and we should be accounting for that for falls and for cardiac health and just general well-being, to be honest, because we live in such a society where there's just always productivity over sleep and rest. So very important point there. Thank you.
Yes, I can't agree more. Without good sleep, we do not function well, whereas it's so much more at risk of falling or even just bumping into things and having an injury in that way. Yeah, and then also not looking after our diet and everything else and not looking after our well-being. Yeah.
Thank you. You guys did an amazing job. I don't see any questions and I don't think you've missed any during your presentation either. So we might just wrap up a bit early this time. Can I just start sharing my screen? Sorry, Helen.
Yeah. Oh.
Thank you. And I'll start with mine. So I wanted to just mention that. Oh, can you see my notes at all?
Yep.
Oh, you can see my notes?
Not your notes,
okay.
No, just the full screen.
Okay, cool.
Yeah.
So I just wanted to mention that the World Falls Guideline is, it goes through and it kind of covers the rigorous details around falls and yeah, and the worldwide evidence-based document that you can look into and read more about. And it was published in September last year. And it kind of mentions a lot of cardiovascular risk factors for falls and how multifactorial falls risk assessments are key. And we should be including cardiac risk factors as well as falls. So that was just something that I know you guys already talked about, but there's another document that is saying that these are the guidelines for all health professionals that work in that space, and to look at these assessments and interventions as something they should be keeping in mind as well. So we did questions. So, and this really lovely ties in with our Improve Your Health campaign. So we're currently at our Improve Your Health campaign for the Stay on Your Feet program. It started in March and will run till the end of May 2023. So it kind of looks at encouraging older adults to stay active, independent, prevent falls, and we look at individual diet, medication intake, and cognitive ability as risk factors, and overall health and well-being, and why that's important to look at when we're talking about falls. And so today we covered all of them really, and how cardiac health links to all of them. So you can always download the campaign toolkit on our website as well. And we have our grants program. So we have applications for Remove Hazards grants open, and they'll be opening next week on Monday, the 3rd of April. So grants of up to $5,000 plus GST will be available for the delivery of community-based falls prevention projects in WA through September to November of 2023. And the Remove Hazards campaign looks at the main focus of that campaign is to raise awareness and knowledge among older adults about removing potential hazards and creating safe environments in the home, as well as eye and foot health to prevent falls. So each grant will be expected to address at least one of those 3 risk factors. So you can read more and have a look at it on our website as well, but that will be launching on Monday. So get your grants going. And then to learn more about falls, we have online learning modules that go through kind of introduction to falls if you want to learn more about it as a health professional. We also have another module for exercises to prevent falls in older adults. So they're free to complete, and they're self-paced as well. So you can just go in and access them whenever you like. We also have a number of trainings and events coming up. So we have the Applying Otago program for falls prevention, and that's catered to OTs and physios. That's coming up on the 2nd of May, and it's a 3-hour workshop for health professionals. If that is something of interest to you and you want to learn more about falls prevention exercise programs like the Otago program, you can attend that one. And then we also have Keeping Dementia in Mind, so preventing falls by creating dementia-friendly homes, and that'll be on the 6th of June as a webinar. So all of these events are on our website as well in the events tab. So make sure you're registered to any of them that you may find interesting. And to keep the conversation from today going, I would highly encourage all the health professionals to join the Community Falls Network. So the Community Falls Network meets quarterly to provide professionals such as yourselves working in the falls prevention space across WA with an opportunity to connect with each other, share learnings and solutions in the falls prevention and safety promotion space. So our next meeting is in May of this year. So if you wanted to be part of that network, just shoot me an email and let me know if you want to get sent emails and a calendar invite. We also have Connected, which is a networking platform for health professionals. And today we'd like to hear more about what you thought about today's webinar, your thoughts, how you found today's webinar, any future recommendations for webinars. So if you, after today, after this webinar ends, there will be a survey that pops up. We really appreciate if you could complete that, because we want to learn more about what you thought about today. And it also helps delivering, for us to deliver trainings that meet your needs. So yeah, that is it from me, and that is it from all of us today. Thank you so much, Helen and Anne-Marie. Thank you for your time to present such an amazing webinar, and I think I learned a lot as well, and it has made me aware of things that I can do personally, and also I hope that everyone has taken some messaging away for their clinical practice as well. So thank you.
Thank you. Thanks for inviting us.